Hi, my name is Brooke Shelton, and this is Casey Clayton. We are speech language pathology graduate students here to talk to you about Crouzon syndrome. First, we will tell you a little about what Crouzon syndrome is. Then we will discuss what causes Crouzon syndrome. Next, we will talk about the symptoms and characteristics present in Crouzon. And finally, we will discuss some treatment options that are associated with Crouzon syndrome. So what is Crouzon syndrome? It is a rare genetic syndrome that was first described by the French physician Octave Crouzon in 1912. It is the result of craniosynostosis, or the premature fusion of skull bones in the developing fetus. It is often also called craniofacial dysostosis and is characterized by various facial deformities. Most babies born with Crouzon syndrome will have a normal life expectancy and normal intelligence.
So now we're going to talk a little bit about the genetics of Crouzon. Crouzon syndrome is caused by a mutation of the fibroblast growth factor receptor, FGFR gene, most commonly FGFR2, which is on chromosome 10. FGFR2 is responsible for making proteins involved in bone growth and development and is responsible for other craniosynostosis syndromes, so those syndromes that involve the premature fusion of skull bones in infants, aside from Crouzon, such as Apert syndrome. Crouzon syndrome occurs from an autosomal dominant inheritance. This means that a child born to an affected parent has a 50% chance of developing Crouzon. However, in about 50% of cases, the genetic mutation occurs spontaneously de novo, which means that they will be the first in their family to carry the mutation for Crouzon syndrome. So a little on incidence and prevalence. For incidence, 1 in 60,000 babies worldwide will be born with Crouzon syndrome, and currently about 1.6 in 100,000 people are affected with Crouzon syndrome. This makes the syndrome rare. However, when it comes to craniosynostosis syndromes, Crouzon is the second most common, only following Muenke syndrome, which is more recently described.
Symptoms will vary from one individual to another and may be mild or severe. The most common craniofacial anomalies include brachycephaly, or wide-set eyes, proptosis, which are bulging eyes, flattened forehead, maxillary or mid-face hypoplasia, cleft lip and/or palate, which occurs rarely, high palate, dental issues such as anterior crossbite, strabismus, which is eye misalignment, and that may also cause vision loss.
So now we'll talk a little bit about hearing loss in this population. In a 2011 study comparing the audiologic profile of children with syndromic and complex craniosynostosis, it was found that 35% of the participants with Crouzon syndrome had mild to moderate hearing loss, with conductive hearing loss being the most common type. Sensorineural and mixed hearing loss were also present for some, however, it was more rare. The hearing loss in this population was attributed to recurrent otitis media with effusion, ossicular chain fixation, which is the presence of fibrous tissue encasing all or part of the ossicular chain, and external auditory canal atresia, which is the narrowing or the absence of the external auditory canal. Hearing loss in this population is often treated with surgery, the use of hearing aids, or cochlear implants when warranted.
Smaller, more narrow oropharyngeal passageways may affect respiration, feeding, and swallowing for babies born with Crouzon syndrome. These babies are more likely to be affected by sleep apnea, upper airway resistance syndrome, or cleft lip and/or palate. Due to the wide range of severity of these symptoms, some babies may require surgeries to repair these abnormalities.
In terms of speech, language, and cognition, between patients, the severity can vary. Often, if speech is affected, it is due to structural differences such as hearing loss, dentition, cleft lip or palate, high palate, or anything else causing a delay or mislearning of speech production. Respiratory abnormalities can also cause difficulties in providing sufficient air support for appropriate speech production. Language is typically not affected for this population unless there is a delay due to hearing loss that goes untreated. Cognition in these individuals is also not often affected, and their intelligence level will often be normal. Of course, Crouzon does range in severity, and speech, language, and cognition can be more affected in others depending on a multitude of factors, such as age of intervention, presence of additional diagnoses, support systems, and more. For most, however, with appropriate surgical and therapeutic interventions, they will go on to live healthy, normal lives.
So, treatment will vary depending on the severity of the symptoms, but it will often involve surgery. Those with more severe craniosynostosis may require a team of surgeons, including oral maxillofacial surgeons, plastic surgeons, neurosurgeons, ENT specialists, and ophthalmologists. Cranial vault remodeling is a procedure often done within the baby's first year of life. This operation allows expansion and reshaping of the skull. Leffert 3 and monoblock facial bipartition advances the midface and is performed between ages 7 through 10. Box osteotomy narrows the distance between the eyes and increases the movement of the eyes and is performed generally after age 12. Orthognathic surgeries may include bite and tooth adjustments, and rhinoplasty may be performed around ages 16 through 18. Depending on the severity, the patient may require additional care with an orthodontist for teeth misalignment.
The speech-language pathologist treating an individual with Crouzon syndrome may need to address many different needs, including the patient's hearing, feeding, articulation, language, and resonance. Hearing tests should be performed regularly. Children with hearing loss may need surgical or medical intervention to correct things such as otitis media, external auditory canal atresia, and ossicular chain fixation. And once in speech therapy, hearing aid and cochlear implant maintenance and usage should be observed to ensure that the patient is hearing at optimal levels for speech production and for receptive language ability.
Depending on the severity of the facial anomalies, a newborn with Crouzon syndrome may require feeding therapy from an SLP and a dietitian. This will involve finding the right bottle that works for the caregiver and the baby. There are several bottles that will help control the flow rate or nipple compression, such as Dr. Brown's Medela or Pigeon bottles. The SLP may also help the caregiver position the baby correctly to allow for proper feeding to occur. Cleft lip and palate associated with Crouzon syndrome should be treated with the same attention as other patients born with cleft lip and palate, and should involve a cleft team dedicated to the patient's well-being. A cleft team usually consists of a craniofacial surgeon, a pediatrician, a reconstructive surgeon, an ENT, a dentist, an SLP, an audiologist, and an orthodontist. Children with cleft lip and or palate may experience hyper or hyponasality and articulation issues due to the structural abnormalities of the lip and palate. These may include abnormal anatomy resulting in velopharyngeal insufficiency, abnormal neurophysiology resulting in velopharyngeal incompetence, and abnormal velopharyngeal learning, which involves maladapted compensatory strategy usage. Please keep in mind that cleft lip and palate associated with Crouzon is rare. There is a higher prevalence of high palate. In a recent study comparing facial and oral characteristics of Apert syndrome and Crouzon syndrome, 0% of participants presented with cleft hard palate, 8.3 presented with cleft soft palate, and 58.3 presented with high palate.
For patients with Crouzon, it is important to take into consideration the history of the patient and to conduct a thorough evaluation to determine their speech and language needs. This includes an oral neck examination to determine that all the structures are adequate for speech production. If all structures are not adequate for speech production, it may be necessary to confer with the surgical team. Articulation therapy to correct for mislearning will also be important for this population, as maladaptive compensatory strategies may have been implemented prior to surgical intervention or hearing correction. Incorrect placement due to high palate, cleft palate, or velopharyngeal incompetence will require retraining by the SLP. Delayed language acquisition may also be present in these individuals, but because most have normal intelligence, targeting age-appropriate language as soon as possible will be important for their continued development. Because the main characteristic of Crouzon syndrome involves facial anomalies, self-confidence and self-image of the patient are something to consider when providing treatment. In a study observing the psychosocial condition of adults with Crouzon syndrome, more frequent periods of depression were observed compared to the control group, and 65.5% of patients had experienced being bullied. If you feel as though your patient is struggling with their self-image or is being bullied or mistreated because of their differences, referring to a counselor or a psychologist may be important to improve their quality of life. Now, a quick word from our friend Brooklyn on how to interact with someone with Crouzon syndrome.
If you could say something to the whole world, what would you say?
I would say just be a nice, normal kid. Don't be a mean person who makes fun of people by how they look.
And this concludes our presentation of Crouzon syndrome. Here is a list of photo credits for the images used on the slides, and here is a list of the references for the information we presented. Thank you very much.